past 7:30. John, do you want to get started?
All right, good morning, everyone. Welcome to our rounds, and please welcome Dr. Crema, who's going to be the lead on these rounds today. So he is, of course, the director of the Ocular Oncology Service of Princess Margaret Cancer Center University Health Network, and he is an associate professor in our department. Now, he graduated from Cairo University. It says the year here, but I can leave that out, and obtained his master's degree in ophthalmology from the same university. And of course, he continued his training into ocular oncology, which occurred in my father's hometown, actually, at Royal Liverpool University. He then also did further training at Baskin Palmer, as well as Wills Eye Institute. So really, the many major centers across the world. And we're fortunate now to have him here in Toronto. He's interested in translational clinical research in the field of ophthalmic oncology, with a focus on better defining algorithms for radiotherapy in ocular and adnexal cancers, management of treatment complications, introduction of innovative surgical techniques, and interpretation of modern ancillary diagnostic imaging, and the role of molecular genomics in identifying patients at risk of metastatic disease. So welcome, Dr. Crema, and our resident team, Yogesh and Seema. Thank you.
Thank you very much. I think we have two cases to be presented first by Seema and Yogesh. So maybe Seema can start, take the lead.
All right. Thank you, Dr. Crema. Everyone can see my slides? Great. Okay, so I'm just going to begin my name's Seema. I'm one of the PGY3 residents, and I'm looking forward to sharing this case with you that I saw with Dr. Crema at Princess Margaret recently. So our patient is an 85-year-old female who was referred from dermatology to the Ocular Oncology Clinic for a 1-year history of a painful ulcerated lesion on her left lower eyelid and cheek. The story of this lesion was that it had grown rapidly over the initial 4 months of presentation and then become quite stable thereafter for the past year. She was otherwise well, with no systemic symptoms and no constitutional signs. Her past medical history included some of the usual suspects, but she was, as I mentioned, at her functional baseline, and there was no relevant ocular history. On clinical examination, you can't help but to notice this large 7 by 5 centimeter lesion on her left lower eyelid. It's quite distinctive for the raised, rolled in epithelial edges that were red, and the center that was filled with necrotic purulent secretions. On examination of her eye, the globe was intact and normal, and there was no lymphadenopathy noted. She'd had several courses of treatment with her dermatology, which had been unsuccessful. This included several courses of topical and oral antibiotics, curettage of the lesion, electrodissection, and cryoablation. Despite all of these treatments, it had not regressed and had actually continued to slowly grow. We ordered an MRI to assess the posterior extension of the lesion. And as you can see here, it extends way down to the periosteum, but does not violate that black line of the bone here. And there was showing no deeper extension. And there were no cranial metastases found on the MRI. She did not have any systemic symptoms for us to prompt a further systemic workup for extracranial metastases. And so I'd like to just turn it to the audience now to begin and ask, what do you think here is the most likely diagnosis? We have several options. The first, mycobacterial abscess. The second, squamous cell carcinoma, basal cell carcinoma, keratoacanthoma, rather an inflammatory granulomatous lesion, or lastly, pseudocarcinomatous hyperplasia. So I'll let that run for a few seconds.
I'll let a couple more votes come in and then I'll share the results with you. You do have a leading choice here, so here you go.
Okay, so interestingly, the majority felt that this would be basal cell carcinoma, whereas others thought squamous cell carcinoma or keratoacanthoma. And I think these are all excellent choices that we'll discuss in a moment. So faced with a large ulcerated kind of lesion like this, there are several key things that you want to consider on your differential diagnosis. First should be infectious lesions. With something that is so chronic and looks so ulcerated and purulent, you have to consider atypical infections such as mycobacterium or deep fungal infections. And you have to consider this particularly in patients who are immunocompromised, who have diabetes, or may have risk factors such as living in a TB endemic country. There are very few inflammatory things that can look so large and so chronic, but considering a history of trauma, you may want to think about things like a foreign body reaction. But of course, the money is really in thinking about our neoplastic entities. And there are several key things that you should think about in this category. The first are basal cell carcinoma and squamous cell carcinoma. Although these typically are a little bit smaller, they of course have the potential to grow to this size. And it's atypical for the remainder of the skin to look so normal. Usually these types of lesions have an indurated appearance in the rest of the face or in that surrounding area. Pseudocarcinomatous hyperplasia is a benign condition that is considered potentially precancerous and is often seen to have a hyperkeratotic or scaled appearance around it and should be something you consider as well. In this case, however, the diagnosis came back from a pathology review as a solitary keratoacanthoma. And we'll take a couple of slides to discuss what this tumor, to discuss the characteristics of this tumor. So keratoacanthoma is a tumor of epidermal origin that originates from the hair follicle. And it has a characteristic natural history. It often undergoes a period of rapid initial growth, then stabilizes for a period of time, and then, interestingly, has a tendency to spontaneously regress without treatment. This tendency for spontaneous regression has raised the question as to whether it's benign. However, in certain cases, it can grow very aggressively and has actually been reported to metastasize elsewhere, prompting the hypothesis that this may be a low-grade variant of squamous cell carcinoma. It typically presents as a small lesion in sun-exposed areas. So, for example, the face, the neck, the arms, or the dorsum of the hands. It's typically a small, raised pink or skin-colored papule that has raised epithelial lips around it and a central keratin plug. Very sometimes, or relatively uncommonly, these lesions can become quite large and are described as keratoacanthoma centrifugatum, where they form these very big crater-like lesions that have central scarring and atrophy, similar to our patient's case. Patients at risk for keratoacanthoma are typically older, so in their 6th to 7th decade of life or beyond. It's more common in males and in patients with fair skin. And as we've mentioned, these patients often have a history of UV exposure, and these lesions may also arise in immunocompromised individuals or in areas where there's been previous skin trauma, such as tattoos, microplaning, or dermabrasion, which can decrease the potential for the skin to regenerate and repair DNA in that area. Keratoacanthoma can also be seen in patients who have heritable cancer syndromes such as Muir-Torre, xeroderma pigmentosum, or Ferguson-Smith syndromes. Biopsy of keratoacanthoma should aim to be as complete as possible. So a total excisional biopsy allows the pathologist to look at the distinctive architecture of this lesion. And when looking at it, often we're looking for the epithelial lip, as well as you can see on the right-hand side, the glassy keratinocytes that infiltrate the lesion and the presence of necrotic abscesses. So differentiating keratoacanthoma from squamous cell carcinoma is one of the most important steps in the diagnosis of this lesion. As we've discussed, keratoacanthoma differs from squamous cell in that there's typically a sharp demarcation from the abnormal tumor tissue and the normal surrounding skin. So that is something that we don't typically see as much in squamous cell carcinoma. Keratoacanthoma is also more symmetric appearing, has an epithelial lip, and is less likely to ulcerate. There is typically also a presence of keratin in the center, and as well as we've mentioned, the intraepithelial abscesses. And although the lack of aggressive behavior does not rule out keratoacanthoma, it is less characteristic. However, it's important to note there is no definitive immunohistological marker to differentiate these two entities. Therefore, the diagnosis is made on several key principles. The first being these characteristic clinical features that we see of the crater-form lesion, the natural history of this proliferative phase that is quite unique to keratoacanthoma, and the excisional biopsy that shows this unique architecture of the epithelial lip. So coming back to our patient, given the size of the lesion, as you can imagine, it was not possible to do a complete excisional biopsy. So looking at the slides from a curettage specimen, the dermatopathologist had commented that it was consistent with keratoacanthoma, but could not rule out squamous cell. And it's possible, given the size, that there were areas of squamous cell within this lesion. I don't think I have to tell you why we decided to pursue treatment in this patient, but some of our goals were, of course, to restore cosmesis in this disfiguring lesion, to preserve function of the eyelid and the lacrimal passages, and to reduce the risk of any further invasion or potential metastases down the road. So I'm going to start the second poll now and ask the audience, in this case, which treatment would you recommend for our patient? First of all, would you consider observation, given the fact that the lesion may regress with a diagnosis of keratoacanthoma? Option 2 would be external beam radiation. Option 3 is local chemotherapy, such as with topical creams or periocular chemotherapy. Option 4 would be systemic chemotherapy, given the risk of squamous cell carcinoma. And number 5, to go for surgical excision and reconstructive surgery. So we'll let that run for a few moments.
Seema, while that's running, can you just comment again on how this resulted in being so enormous despite seeking care? Like usually these patients show up because nobody's seen them. I mean, this patient had seen dermatology, she'd had some stuff done. I mean, how did it grow to that size while under active care?
So that's a great question. I mean, she had been followed closely by her dermatologist, and they had been trying different treatments. So, you know, that had been, you know, she had been closely monitored, and they had tried multiple courses of treatment that had failed. So it was really to be referred for, you know, and we'll discuss here, more invasive treatment at this point. But I think there may have also been some pandemic related delays because it had happened over the course of the past year. So it wasn't for lack of care or treatment, it was just that it had been a very resistant lesion for this poor patient.
I think there is another element, is a secondary infection to the lesion. It perpetuates the lesion persisting. Like it was full of pus and necrotic material, so that also contributed.
So the biopsy that you had read was done by the dermatologist?
By a dermatopathologist.
What I mean is the person performed it. You guys didn't do a separate biopsy?
I don't believe so. Dr. Krema may know those specifics further, but I believe it was done by the dermatologist, and then the treating dermatologist read by a separate dermatopathologist, and then we did not do a second biopsy.
Okay, just because rather than jumping to excision of this large lesion, you could do an aggressive pie-shaped biopsy at the inferior edge, which includes the central crater and goes down to the periosteum. For two reasons. These can harbor a squamous cell, as you said, and especially with that periosteal invasion on the MRI, that's a little worrisome. And secondly, a pie-shaped biopsy like that might induce regression. So that's what I would do as a next step.
Well, in this patient, we did kind of talk about, you know, next steps and where to go from here. And one of the things, and as we'll go through, we did talk about proceeding with some form of excision or surgery. So I'll just review some of the treatment options and talk specifically about some of those points that you mentioned there. Thank you for that helpful comment. So, you know, one of the common treatments for keratoacanthoma is curettage and cryotherapy. And as we've discussed, this had previously been attempted by the treating dermatologist and had been unsuccessful. Surgical excision, whether total or subtotal, was something that we discussed with the patient. But of course, this is a very large area excision and would have required major eyelid reconstruction. The patient was actually referred for consultation to head and neck surgery. And they were very hesitant to go ahead with this, given the large-scale reconstruction that would be required. And as well, the fact that given there could be a deeper squamous cell carcinoma, they discussed with the patient there'd be a risk of exenteration to achieve clear margins. And the patient was very, very hesitant to undergo any treatment after this was mentioned. She was also then seen by radiation oncology for consideration of external beam radiation. But again, in this case, because radiotherapy induces acute tissue necrosis of both the tumor and the healthy tissues with ischemic changes, it makes future reconstruction very challenging. So we reviewed the literature and found reports of intralesional chemotherapy that has been used extensively in the dermatologic literature, but had not previously been used for periocular lesions. So we had a long conversation over several sessions, I believe, with the patient, and given informed, had an informed consent discussion. And she elected to try intralesional chemotherapy. And we discussed that this would either be, as an adjuvant or neoadjuvant treatment, allowing perhaps surgery to be done at a later date on a smaller lesion, or if it was possible to use it as a sole treatment, we would also be able to try that. When we're talking about intralesional chemotherapy, we're specifically talking about methotrexate, which, as we all know, is a folic acid analog, which blocks DNA synthesis in rapidly dividing cells. And as we mentioned, it's been used in the dermatologic literature, both as a sole treatment for keratoacanthoma, but also as a neoadjuvant or adjuvant treatment, and has a fairly high resolution rate, approaching 90%. So in this case, we performed this as an in-office procedure. We infiltrated the lesion with lidocaine and epinephrine, and then locally debrided the necrotic tissue down to the base. And we pursued weekly injections of methotrexate, 2 milliliters composed of 25 milligrams per milliliter, using a 27 gauge needle to the base and the floor of the lesion. At the end of each session, we packed the floor with povidone iodine gauze, and the patient would apply polysporin every day until she returned the next week for her repeat injection or repeat treatment. And as you can see from these images here, she did quite well. So she received 4 treatments over the month every week with debridement at each session. And after 4 injections, you can see there was a rapid improvement, but after 4 injections, the rate of healing slowed. And we wondered whether the cytotoxic effect of the methotrexate could be inhibiting healing. At this point, we therefore decided to stop treatment and to simply observe. And as you can see, the skin closed by secondary intention in approximately 2 weeks. So methotrexate for periocular keratoacanthoma, as we saw in this case, may actually mitigate the need for the complex eyelid and facial reconstruction surgery that would be otherwise required, and help to avoid the necrotic and ischemic effects of external beam radiation. The reason this is so, this can be effective, is because it induces a much slower necrosis and ischemia of the affected tissues, while the rich vascular supply of the eyelid and the face allows slow kind of healing at the same time, reducing the risk of residual deformities and reducing the risk of impairment that affects the periocular structures. As well, this is much more suitable for an in-office treatment, which minimizes our risk of anesthesia. However, it's really important to be careful when thinking about methotrexate, because it would not be an effective treatment for squamous cell carcinoma or treatments that have a much deeper invasion. And as we discussed in this case, we were initially kind of considering it as a neoadjuvant treatment, but it did have very good success, and we were able to use it as the sole treatment. So in terms of our take-home points, I just wanted to highlight that keratoacanthoma is a lesion that we can see around the eyelid and must be differentiated from squamous cell carcinoma through the clinical examination, the history, and a good biopsy from the representative tissues. And to consider intralesional methotrexate as an effective treatment option for these resistant periocular cases to attempt to minimize treatment morbidity. So with that, I just wanted to say thank you and acknowledge Dr. Crema and Dr. Altamari's help in preparing this case, as well as acknowledging the fellows at Princess Margaret and the photographers, which were really instrumental in putting this case together.
Great, thank you, Seema, very much. Excellent presentation. As she mentioned at the end, the intent of using methotrexate was as a neoadjuvant treatment, because we couldn't tell really if every cell there is just keratoacanthoma or squamous cell. So we wanted to shrink the tumor to the smallest size possible before we tackle it surgically or with radiation. But we've seen it like completely cured with the just 4 injections. The injection, by the way, costs about $25. So the whole treatment costed less, about $100. And the gradual necrosis with simultaneous regeneration over a month produced this excellent result at the end without any compromise to eyelid function or the lacrimal passages.
It's a great result.
Yeah.
Tim, that's remarkable resolution. Why would this not be first-line treatment for keratoacanthoma?
That's what we'd recommend, actually. Actually, we published it into a paper coming soon to the Canadian Journal, and that's what we'd recommend. I think this is what we should start with, particularly when you have a resistant case. The small ones sometimes regress, or mostly they regress by themselves after some time. But if it becomes large like this and necrotic, it's worth trying it as a first-line treatment.
The pathology in these cases is sometimes very, very difficult. I've had a number of patients over the years that the pathologists have argued, is it a squamous cell or is it a keratoacanthoma? And you get differences of opinion. I'd be careful in saying that this patient is completely cured. I think you have to keep following this patient along. I've had a few patients over the years with classical keratoacanthomas that have come back as squamous cells later on. So I think this patient has to be followed for a long time.
Yeah, we do that. We keep her under observation every 4 months. It's been, I think, like more than 6 months since she finished their treatment with no recurrence. But obviously, yes, we keep her under observation.
Along those lines, there was a small nodule on the side of the nose at the inframedial, where the inframedial edge of the big lesion was.
Yeah, she told me that has been pre-existing for a long time. I don't think it's
probably just a nevus then.
Now we have Yogesh. I think he has also an interesting presentation. You can proceed.
Pull that up there. Perfect. Well, good morning, everyone. So my name's Yogesh Patodia, one of the PGY3 residents, and I've got a fun case for you guys today entitled "They Call Me Mellow Yellow," after the fabled 60s song there. So we'll get right into it. So it's a 65-year-old lady that presented to the ocular oncology clinic with 6 weeks of progressive left eye pain, photophobia, and blurred vision. Now, she was seen by a hospital in Toronto, one of the ophthalmology departments in Toronto, for a retinal detachment. But on B scan at that time, there was a suspected lesion. And so she was sent to the ocular oncology clinic to rule that out. Of note, she had no past medical history. Cataract surgery was her only ocular history. And she was a lifelong non-smoker with occasional alcohol use. So of note here with her exam, she was 20/20 in the right eye and hand motion in the left. Pupils equal round reactive, intraocular pressure of 12 in the right and 8 in the left. And most strikingly here, I'd like to show you our anterior segment photos. So as we can see, in the right eye, everything appears to be relatively normal for the most part. But the left, obviously, the most striking feature here is the yellowing of her sclera or episclera, almost similar to scleral icterus. So this kind of gets into our first poll question here is you see this patient in your clinic and what is your kind of next step in management? And there could be a couple different options here, a couple different choices that you could go with, but would you call internal medicine for, a consult, rule out jaundice? Would you say, hey, let me see the fundus first? Would you order an AST, ALT, bilirubin just to get the process going quicker? Or again, a combination, one and two, or would you just do everything? Perfect. Exactly. Good. So yeah, all the above I think was a good choice, but I'm glad, again, most people said, hey, let me see the fundus. So let me show you the fundus. So as we can see here, the right eye, fundus photo out into the periphery looks relatively normal for the most part. But again, the most striking feature here in the left eye is there's multifocal areas of detachment, both serous retinal detachment, as well as choroidal detachment, that it's kind of circumferentially 360 around. And again, this kind of explains our hand motion vision. B-scan ultrasound of the eye as well too showed again multifocal areas of both serous detachment as well as this 5.8 millimeter mass with medium internal echogenicity. And then as well a UBM image here just showing a ciliary effusion or basically an effusion syndrome here in the superciliary space. So then my next poll question that I wanted to ask everyone was, where do they think the lesion is with regards to the fundus photo here? So is it in section A here, kind of at the top? Is it over here in B where it's a little bit dark? Is it over here in C, again, where we can't quite tell? Or is it over in region D? And this one we can go pretty quickly as well.
We seem to have consensus around one, so I'll end the poll here.
Perfect. Okay, good. I was able to sort of trick everyone. That was kind of the goal, I think, of this. Fantastic. So getting into it, Again, just a little quick recap that this was a very atypical presentation. Again, we had a 65-year-old lady that presented with pain, decreased vision, and this serous/choroidal detachment with, plus minus the mass for the most part. And I just wanted to point out that the actual mass was nasally here, this white lesion here. So again, it was a little bit of a trick. But at this point, the presumptive diagnosis kind of included peripheral exudative hemorrhagic chorioretinopathy, an atypical scleral uveitis, given there was a lot of sort of serous detachment, choroidal detachment, again, kind of atypical, or obviously an intraocular tumor. So at this point, she was started on oral prednisone and an MRI was ordered. We fast forward 1 week and her pain improved, but obviously her vision was still quite poor. And given the lack of response to the steroids, it was less likely in keeping with an atypical scleral uveitis. But again, looking at the MRI here, we see a T2 weighted post-gadolinium MRI of the orbits here. And you can see these sort of two multifocal masses or lesions. Again, this one looking a little bit more solitary, and this one more in keeping with like a choroidal hemorrhage. So again, heme that's maybe potentially clotted off there, but again, difficult to assess. So getting into our last poll question now, we finally said, okay, there really appears to be a mass. Now the question comes is, where do you believe the etiology of this location is? The etiology of this lesion. So again, do we think it is a primary ocular melanoma? Is it a choroidal hemangioma? Or do we think it's maybe a metastasis? Again, given that she was healthy. And this one will be a quick one too. Fantastic, good. So we got people thinking about metastases, and that's exactly what we're concerned about here. So at this point, this is what Dr. Krema and the team were thinking as well. And a CT abdomen, chest, or thorax, abdomen, pelvis was ordered. And as we can see, unfortunately, in the left lung here on the upper lobe, she had a large lesion. And after biopsy with fundal aspiration, it was found that she had adenocarcinoma of the lung, as well as additional metastases found in the T12 spine as well. But again, asymptomatic for the most part. So she was immediately started on systemic chemotherapy with entrectinib, again, ROS1 specific, looking at a marker for her adenocarcinoma, and external beam radiation to the mediastinum and orbit were started. And as you can see, 3-month follow-up, there's a significant improvement in the size of her actual lesion intraocularly here. And then forwarding out to 6 months, her systemic treatment was switched to pembrolizumab, again, another marker that was positive for adenocarcinoma. And we can basically see almost complete resolution of the mass within the eye. And again, looking at the fundus photo here, you can kind of see the outline of where the mass sort of was left over there. But unfortunately, given the long-standing retinal detachment, exudative detachment that she had as well, unfortunately, her best corrected vision ended up being hand motion. So this gets us into the talk about choroidal metastases, and a really big study out of the Wills Eye Center, again, big center for tumors, found that the uvea, the most common location for mets typically are in the choroid. Again, specific to the uvea. And of note, the tumor origin most likely is related to the breast. Again, majority of breast tumors do metastasize to the eye and the uvea, but lung following quite closely behind that. And then a grab bag of other tumors like kidneys, GI, and like the lung carcinoid. So when you have a unique patient like this, you kind of have to have a very wide differential diagnosis. But again, things don't quite fit in to her picture. Of course, malignancy is kind of number one on our differential. We think about a choroidal melanotic melanoma, a hemangioma, a metastasis. But of course, given that she had this sort of extensive, serous detachment, we also kind of have to think about maybe posterior scleritis, a uveitic effusion syndrome. Again, VKH, a little atypical for that. Or solitary idiopathic choroiditis, as well as rule out infectious lesions like TB or granulomatous uveitis like sarcoid. As I mentioned, what's kind of unique about this case was this is less likely in keeping with a primary ocular malignancy, given that she had a significant amount of choroidal detachment and serous fluid accumulation. This is less in keeping with primary tumors and more in keeping with metastases, more likely hypothesized due to the fact that there's rapid growth with these mets. What also, as we saw, was interesting about this case too, was that she had this yellowing of the episclera of her sclera. And again, yellowing, as we know, is a clinical sign of jaundice that's often bilateral, and it's a elevation in bilirubin that gives you the yellowing of the eyes. But again, our lady only had it in the one eye. And so the thought was that she had scleral impregnation of local hemolysis around the choroidal heme that was there. They kind of extravasated out to the episcleral space and then re-impregnated into the sclera. Again, we weren't able to confirm whether or not this was actually impregnated into the sclera itself, but there was a significant collection underneath the episclera, and it appeared to be in the sclera as well. So just a quick chat on treatment and prognosis. So for her specifically, her adenocarcinoma was positive for a few markers on cytogenetic analysis. And so that always is the mainstay whenever it comes to adenocarcinoma or any sort of lung carcinoma for the most part. As well, for her, local treatment was a very important thing. Proton beam radiation has been shown to have about 84% success rate. And for her, it really had great tumor control and glow preservation. And the complications typically are quite low, mainly because the amount of radiation that's being used is about 1/5 of what's typically used in other tumors and primary tumors. So things like radiation retinopathy and optic neuropathy are quite rare, and they tend to do very well. Now, of course, given that she's had stage 4 metastatic adenocarcinoma, the prognosis, believe it or not, unfortunately, is about 7.5 to 13 months. So given that it's quite late stage, the prognosis is quite poor, but you know, she seems to be doing well at the moment. So it was well caught by the initial team. So again, just a quick presentation, but I'd like to thank Dr. Crema, Dr. Weisbrod, and Dr. Altamare, as well as the fellow, Dr. Lando, and the awesome imaging staff at PMH. And then I just actually wanted to put a quick plug out for the PMH clinic. Highly recommend all the junior residents to visit when they have an opportunity to go. I don't think we get enough of it, and it's a very high yield place to visit. When we were chatting with Dr. Crema about wanting to present some rounds, I had this very interesting case that I saw at St. Mike's of a person with a melanoma. And I said, oh, this is a really cool case. Can I present this? And Dr. Crema said, you know, listen, they want us to talk about melanoma. Let's show them something interesting and fun. And so I said, okay, fine. But again, I just wanted to let junior residents know it's a great clinic to go visit. I highly recommend doing it when you're on your retina rotation. And if you ever have a very difficult case that you can't tell, you know, when you're on call, if you put up your phone with your flashlight on, and then you're recording a video, you can just use your lens to actually give you kind of an indirect view, and you can get a good image that you see there. So thank you, everyone.
Well, thank you very much, Yogesh. Obviously, I paid him to say this at the end. So yeah, that was an unusual presentation for a patient coming with a yellow conjunctiva or subconjunctiva, and turned out to be the first sign of lung cancer. Any question to Yogesh? Okay, so I have a presentation here. I wonder if you see my screen.
Yep, that's perfect.
Okay. So in my talk today, I'll try to highlight the significance of the multidisciplinary collaboration in creating management plans for the patients of advanced ophthalmic tumors. So by advanced ophthalmic tumors, these are the extensive, recurrent, or tumors that are involving multiple structures or tissue planes. They usually represent a treatment challenge. So not long ago, the typical treatment for any intraocular cancer was enucleation, and for periocular and orbital cancers was wide excisions or orbital excentrations with various modifications. While we still perform, obviously, these procedures for a curative intent in some advanced cases, they could be avoided in several other situations by implementing treatment plans that would include multiple treatment modalities. Multidisciplinary approach, which is combining several oncology treatments, is a standard practice in the management of several systemic cancers. In fact, most health authorities around the world, including Cancer Care Ontario here, require the implementation of a multidisciplinary decision-making in cancer management to provide optimal treatment strategy for the challenging cases in order to obtain the best outcomes. With the recent rapidly growing knowledge, technology, and treatment protocols in different fields of oncology, the ophthalmic oncology specialty is set to orchestrate the treatment plans for these advanced ophthalmic tumors. The ocular oncologist combines the required ophthalmic surgical skills for treating intraocular and periocular tumors with the full knowledge of the application of other cancer treatments, such as the potentials and limitations of different forms of radiation, the cancer drug therapy, including the cytotoxic drugs, targeted therapy, and immunotherapy, and also the rising role of tumor genomics in determining the treatment course and prognosis. With respect to the radiation role, there are several types of radiation treatment that we are currently using for periocular tumors. Orthovoltage radiotherapy is a form of deep X-ray commonly used by the dermatologist and is applied for selected tumors of the eyelid and palpebral conjunctiva. External beam radiotherapy with high radiation energy is suitable for some deeper and anterior orbital cancers that do not involve the ocular surface. Plaque radiotherapy has been established as a primary treatment to the majority of intraocular tumors. It's also used as a primary or adjuvant treatment for a variety of ocular surface cancers, particularly with scleral invasion. Modified electron beam radiotherapy is an efficient treatment for low-grade neoplasia involving the conjunctiva and anterior orbit, such as lymphoma. With regards to the drug therapeutics, there are currently several chemotherapy, targeted therapy, and immunotherapy drugs that are used in the treatment plans of ophthalmic tumors. These agents can be used in an adjuvant or neoadjuvant settings. Close collaboration with a medical oncologist is vital to tailor a treatment plan in case of systemically administered drugs. However, many agents can be administered locally by the ocular oncologist, as we've seen in the case of this morning. In the following few minutes, I will be presenting examples of patients with advanced cancers who were treated through multidisciplinary management. Starting with periocular tumors, the mission here is to avoid exentration. This patient was referred for a large recurrent ocular surface and anterior orbital squamous cell carcinoma. She has had 3 previous excisions, and she presented with this large mass occupying the medial bulbar conjunctiva and invading into the middle orbit through the MRI. So the plan here was to continue. We cannot apply radiation directly on the ocular surface external beam, so the plan was to do a tumor excision with cryotherapy to the conjunctival edges and to remove the tumor down to the orbit, and any residual microscopic disease would be treated with adjuvant external beam radiotherapy to the anterior orbit, avoiding the eyeball. Big size the tumor, treated the patient with 15 sessions of external beam, and she has been treated with no recurrence after 3 years. Second example here is a patient who has a partial excision of a periomorphic adenoma of the lacrimal gland some years ago, and he started to notice proptosis happening again. MRI revealed a deep, larger residual component. So the lesion was so close to the optic nerve. So we decided to do an excision biopsy and followed by IMRT. IMRT is intensity modulated radiotherapy. It's a delivery technique of radiation that can shape the radiation beam. So it delivers its energy at the target volume, avoiding the nearby sensitive structures. That's in case if it shows malignant component. So we did a surgical excision of the residual part, and the pathology revealed periomorphic adenoma with a malignant component. The patient had the IMRT therapy. 6 months, there was no evidence of residual tumor, and 30 months later, still no recurrence. Third case here was this young lady. She presented with a large limbal mass with a scleral component. The mass was overtly amelanotic. However, there was a pigmented part within it, and the intrascleral component looked brown, suggestive of melanoma. Imaging showed no intraocular component in her. So the plan was to do excision biopsy, then we put an episcleral plaque radiotherapy to treat the scleral component. So after surgical excision, the pathology confirmed that the lesion was actually a melanoma as clinically suggested. And the plaque treated the residual component in the sclera. Here we use a plaque to hit to a depth of 3 millimeters to include the entire sclera without causing radiation damage to the retina underneath. No recurrence after 2.5 years. Sometimes when the diagnosis is already evident, we do not need a biopsy. This patient presented with recurrent ocular surface melanoma. She had the tumor excised twice before, and she presented with this light brown mass attached to the sclera with pigmentation around the limbus. So the plan here was to do the full treatment in one session, is to combine the tumor excision, the cryotherapy, and the plaque radiotherapy in one surgery. So in that surgery, we defined the tumor extent. We performed the surgical excision of the mass. We did cryotherapy at the conjunctival margin and applied the plaque radiotherapy to treat for any seeds in the sclera. The patient did remarkably well, and there's been no recurrence after 2 years. This gentleman presented with a large, slowly growing epibulbar tumor that it was so large that it was impossible to open the eyelid to take a biopsy from to identify its nature. The MRI showed that, however, that the lesion is sitting on the eye and it's not invading the eye globe. So we performed a biopsy through the lid margin, through the eyelid, that showed that the lesion is a moderately differentiated squamous cell carcinoma. Obviously now the eyelid is contaminated with cancer cells and has to be included in the treatment of this tumor. Because of the large size, we talked with the medical oncologist who suggested that we can start with an immunotherapy as a neoadjuvant treatment to achieve chemoreduction, kind of downstaging, followed by surgical excision or radiation, whatever is applicable for the residue. And obviously, we will include the eyelids in the radiation. So we started him on anti-PD-1 treatment, and the tumor showed remarkable regression after 4 months of immunotherapy. It's easy for eventual excision, and we would treat the eyelid with orthovoltage radiotherapy. In another setting, we have an excisable tumor. So this is a patient with Merkel cell carcinoma metastatizing to his chest wall, and he developed swelling of the lacrimal gland on one side. We suspected that this is possibly Merkel cell carcinoma metastasis to the lacrimal gland. So the plan here was to do a surgical excision followed by checkpoint inhibitor therapy, which is what the medical oncologist suggested for his metastatic disease. And that will treat any residual microscopic disease in the lacrimal fossa. So we performed excision of the tumor from the lacrimal gland, and it's confirmed that it's a Merkel cell carcinoma. And step 2 here was to use nivolumab, which is the checkpoint inhibitor, and the patient showed no recurrence after 12 months of immunotherapy. So this is because we started with an excisable tumor. We've done that, followed by the chemotherapy, opposite to the other case, which we started with the chemo as a new adjuvant, followed by the surgery. And recurrent extensive sclerosing types of BCC of the eyelid and orbit, that if the tumor is so extensive beyond the capacity of radiation or requires major surgical reconstruction, excision and reconstruction, there is the vismodegib now, which is a targeted therapy that works on the sonic hedgehog pathway in advanced basal cell carcinoma. And it shows good results as a neoadjuvant treatment. So the goal here was to use it followed by radiation or surgery for any residual disease. Unfortunately, this drug has lots of systemic side effects, so patients cannot maintain it for a long time. So we used it with a neoadjuvant intent, and after 4 months, most of the lesion resolved except for a small lesion that was subsequently controlled with radiation treatment. There's been no recurrence in this case after 2 years. Now, this is a very interesting case. This patient has been seeing ophthalmologists and being treated for red eye for almost a year by medications, Tobradex and antibiotics. And she ended with referred to Dr. Rootman, and I commend him for picking the diagnosis clinically. He noticed the presence of a brown spot here, and he referred the patient to us, suspecting that this could be an amelanotic melanoma. The lesion was actually invading the insertion of the extraocular muscles, and it has a nodule extending to the anterior orbit. The incision biopsy done confirmed the diagnosis. Now we're facing a dilemma. This is a tumor occupying 3/4 of the vulvar conjunctiva and extending to the orbit. The only option, obviously, is exentration, and we offered that to the patient, but she refused. We cannot apply radiation directly to hit melanoma. Melanoma requires a high dose of radiation. We cannot hit directly the eyeball with radiation because it's going to cause scleral melting and corneal melting. So the idea is to do an extended enucleation, then radiation therapy to the orbit, since there is no eye to worry about, as an alternative to exentration. So this is what we've done, is that we've done enucleation, including the entire mass with the orbital extension as one lesion. I was left with 1/4 of the conjunctiva and shreds of the tenon, but I could put an implant inside and close the muscles and with whatever left of tissues. Obviously, she had a contracted socket. She has been treated with radiation treatment, and after 6 weeks, we put an amniotic membrane, and we could fit her with a prosthesis and functioning eyelids that yielded a good cosmetic outcome. There has been no orbital recurrence since the radiation after 2 years. Now, that was also another challenging case, a patient with extensive ocular surface melanoma that involved the upper and lower conjunctival fornices with large masses, but virtually the melanoma was everywhere in all surfaces of the conjunctiva. So that was also a case that would have been treated conventionally by exentration. But we decided to go on a treatment plan. First, surgical excision of the melanoma, the large melanoma at the conjunctival fornices, upper and lower. And that was the look of the conjunctiva after surgical excision. Then I had a talk with the radiation oncologists after we read a couple of articles about people who used unshielded plaques, meaning the plaque hits on either side, front and back. So that can hit the palpebral and bulbar conjunctiva simultaneously. So that's what we've done. We've performed periotomy, separating the conjunctiva from the sclera. Did a Gunderson flap, closing the conjunctiva over the cornea. So now the conjunctival sac is one continuum. We did pre-placed sutures for the plaque at the medial and lateral canthal tendons. And we did pre-placed tarsorrhaphy sutures. And then we put this unshielded plaque on the surface. So it hits on the bulbar conjunctiva, and when we do the tarsorrhaphy, it will hit on the palpebral conjunctiva as well. And the tarsorrhaphy. And the patient's visit after 8 weeks, there was complete resolution of all melanoma cells. I have to admit that this patient had a big time dry eye, and probably he would have needed limbal stem cell because his cornea was sounding weak. Now, there is a role for multidisciplinary approach in advanced intraocular tumor. And here the mission is to save more eyes from inoculation. So early on, we had cases of posterior recurrence of choroidal melanoma after plaque radiotherapy when we used the conventional rounded plaque. These plaques would not be able to cover the edge of the tumor near the nerve. It's around, and the edge to one side might be missed and might show regrowth later. So the standard treatment in those cases was to proceed with inoculation. However, we faced patients who refused the inoculation, and again, we talked with the radiation oncologists, and they suggested maybe we can try to do external beam radiotherapy as an alternative to inoculation, since they practice this with brain tumors. And that sounded a good idea, since reinsertion of a plaque with all the adhesions from the previous surgery might also make control of the recurrence difficult. So we started to do that on some of the patients for the past 5 years. And we had so far 26 cases. The tumor recurrence control reached 100%, and the globe salvage was achievable in 84%. Some cases had to go to inoculation anyway because of the radiation complications. The eye has been hit twice by radiation, so we had to inoculate, I think, 4 out of the 26 cases. But we saved 22 cases. Nowadays, we do not use the conventional plaques for those juxtapapillary tumors. We use deep notched plaques that can embrace the nerve and cover 270 degrees, so they can hit on tumors like encroaching on the nerve up to maybe 100, 200 degrees of the circumference. Now we face also cases like this multifocal intraocular uveal melanoma. This young lady, she presented with a ciliary body melanoma at 1 o'clock meridian, but her tumor was scattered everywhere. Like you can see small seeding here on the iris surface. And there was another tumor opposite to the first one, probably from gravitation of cells at the inferior angle, forming another mass here. So you have a tumor like almost involving the entire iris surface and the ciliary body in 2 opposite locations. Again, the standard of care in this situation for such a diffuse tumor is inoculation. But we, sitting with the radiation physicists, we could fashion an asymmetrically loaded large block that can cover the entire ciliary body and iris. It's put on the surface like a contact lens, and the energy distribution within the block is to serve the purpose that it can hit hard on the thick tumors and hit lightly on the iris surface to prevent iris atrophy. So we designed the physics planning sheets, tumor on either side with lots of seeding, and we asked it for high energy up and down and low energy in the middle, and they reproduce that, we could control the tumor successfully. The patient developed cataract, but she removed it and she sustains a vision of 20/40. She is a very grateful patient, and she's one of the big donors to our service. Last case I'm presenting this morning is those very large melanomas. So COMS study suggested that we proceed with inoculation for tumor height more than 10 millimeter. Actually, we ventured with block radiotherapy for tumors even 12 millimeter or maybe 12 and a half. And we had a successful tumor control, but at the expense of producing severe radiation, retinopathy, and neovascular glaucoma. So we control the tumor, keep the eye, but with lots of complication and possibly no vision. So sometimes we face a situation like this, patients coming with a large melanoma and it's in his better seeing eye. This patient has a tumor of 15.2 millimeter. It's not possible to treat this with radiation without completely damaging the eye. So the only option here would have been inoculation. However, I'm lucky to work with Dr. Altomari, a retina specialist. We started a few years ago to perform tumor endoresection. That's to take most of the tumor surgically out by vitreoretinal techniques, and then apply a low dose block radiotherapy to treat any residual tumor cells left in the sclera or at the base of the tumor. So far, to my knowledge, we have around 15 cases that we've done and showing excellent results in controlling the tumor and preserving the vision. So this is this patient after treatment and the radiation, no tumor at the base, and there's been no recurrence, and the patient maintains a good vision of 20/40. So to sum up, I quote here the Mies van der Rohe. This is a postmodern German-American architect who came with the sentence, "Less is more," to describe his style. And I find this aphorism echoes with my talk today, is that multidisciplinary management of selected advanced ophthalmic cancers provides complete tumor control with less need for extensive or mutilating surgeries and more preservation of the ophthalmic structures and functions. And thank you very much.
Well, excuse me. Thank you all very much. Excellent talks from our residents, and a marvelous overview of the kind of work you can do to save eyes and the multimodal treatment of the cancers. Very, very impressive. We're getting close to the end. Any final questions for our presenters? And if not, I just have one final question. Yogesh, I was impressed. That was a neat little video you showed there. That was your iPhone and an indirect. I've done that on the slit lamp. I've never seen that before.
Cool. It's actually really straightforward to do, believe it or not. It just takes a little bit of practice getting the focal length of the lens, and you just essentially, you don't even have to have an indirect on, but you basically just have your iPhone on video with the light on, and essentially you're just getting the lens. Once you get it in focus, basically you get a nice view, and it obviously changes as they change directions, but as you can see, like, you can basically do a peripheral retinal exam for the most part with an indirect in the iPhone. So yeah, it's a lot of fun to do. Actually, you get a lot of really cool images. I've got like CRAOs, masses, nice. RDs, tears. It's fun. Right on. And again, amazing work saving eyes at Princess Margaret. Really astonishing. Thank you.
Great talks, Great talk this morning, guys. That was fabulous. Thank you.
Yeah, well done. Excellent rounds. Thank you very much.
Excellent.
All right. Have a good day, everyone.
All right. We'll see you next week. Bye-bye.